Good afternoon, everyone. Thank you for coming to the GI Grand Rounds. We're very proud to have our two senior fellows, Maryam Shambayati and Rakesh Kumar, here to present their research during their fellowship. I don't have any disclosure. None of the fellows have any disclosures as well. Rakesh Kumar is our third-year fellow who did his medical school in King Edward Medical University in Pakistan and did its residency in Harlem Hospital, and has been with us for the last 3 years. His research, he's talking about the mean platelet volume as a marker of inflammation in inflammatory bowel disease. And we do have a lot of markers we look for, clinical and lab markers for inflammatory bowel disease. But again, his focus was trying to find another novel marker that might help us maybe able to do some non-invasive way of looking at the inflammation in the IBD as well. Maryam Shambayati is our other third-year fellow who has graduated from the University of North Texas College of Osteopathic Medicine and did her pediatric residency in UT Houston, and again has been with us for almost 3 years. And her background with osteopathic medicine, I think she made it to good use because we see a large number of functional abdominal pain in our clinics, and we have difficulty in managing those kids. It's a multidisciplinary approach as well. But one of the unique things was that the osteopathic things have never been explored. So I think Maryam was brave enough to explore that option, and I think she's going to talk to us about that as well. So I think I'll go ahead and present Rakesh Kumar to come and please present your research. Thank you.
Good afternoon, everybody. So I'm going to talk about this mean platelet volume and inflammatory marker in pediatric inflammatory bowel disease. I have no disclosures. The principal investigator for this research are Dr. Marshall and Dr. Grunow. So inflammatory bowel disease is a chronic intestinal tract disease characterized by relapsing and remitting inflammation. Crohn's disease and ulcerative colitis are two main types of the IBD. Crohn's disease can affect anywhere from mouth to bottom, and ulcerative colitis affects the large intestine. The exact cause of the IBD is not known, but it is thought to be a complex interplay of the microbiome, immunologic, and environmental factors in genetically predisposed patient. As Dr. Altaf told, disease is assessed by a combination of the symptoms, physical examination, lab values, radiological studies, and endoscopy with histology. Endoscopy is the gold standard for diagnosis and monitoring of the disease, but it is invasive and costly. Other biomarkers are C-reactive protein, erythrocyte sedimentation rate, white blood cells, platelet count, albumin, and fecal calprotectin. These biomarkers are non-invasive but have varied in accuracy in determining the disease activity. The search for new biomarkers to determine the disease activity, correlation with other available inflammatory markers, and with endoscopic remission has been the focus in the IBD research. There are a number of studies suggesting the role of platelet in IBD inflammation. Platelet function as a pro-inflammatory cells in addition to regulate the homeostasis. There is a growing evidence demonstrating that platelet play a crucial role linking the coagulation and inflammation in IBD patients and start a vicious cycle where inflammation and coagulation propagate and augment each other. The elevated concentration of the platelet during the period of the increased clinical activity was first noticed in 1968 in the case series of the IBD patient. We also note that platelet consumption increases during inflammatory process. So whenever there's an inflammatory process, the platelets want to go there to be consumed, either to augment the inflammation or to regulate the inflammation. And studies have shown that inflammatory mediators increase the platelet production by the bone marrow because there is a more consumption. And when there is a more production, it always happens at the cost of the maturation time. And the net result is the small platelet in the circulation. During the process of inflammation, several morphological changes occur in the platelet indices. That can be a platelet distribution width, platelet crit, and mean platelet volume. I'm going to talk about the mean platelet volume today. So mean platelet volume is a machine calculated measurement of the average size of the platelet, and it is a marker of the platelet function and activation. There is a correlation of the platelet indices with other inflammatory markers like CRP and ESR. According to the study by Oster and his group, there is a statistically significant decrease in MPV in patients with active ulcerative colitis and Crohn's disease. So the patient who had an active disease, either ulcerative colitis or Crohn's disease, their MPV volume was low. Yexel and his group and his associates concluded a statistically significant decrease in MPV in patients with ulcerative colitis compared with the healthy controls. They also looked at the correlation between the MPV and the endoscopic activity index and found a negative correlation. So the patients who had an active disease had a low MPV. The study by Jeremo and his group demonstrated low MPVs associated with active IBD, and other study concluded the significant decrease in the MPV level in Crohn's disease patients with the healthy controls. So all these studies that we discussed are on the platelet indices in IBD are in adult population. There is no pediatric study to look at the platelet indices in correlation with other inflammatory markers. So keeping in view of that background, we proposed a study. The primary aim of this study was to look at the correlation of the mean platelet volume with other inflammatory markers like CRP, ESR, platelet count, and albumin in pediatric IBD patients. So that is an objective data. And the secondary aim of this study was to look at the correlation of the mean platelet volume for the assessment of the disease activity using pediatric ulcerative colitis activity index, we call it PUCI, and with short pediatric Crohn's disease activity index, PCDI, and to look the correlation of MPV with the physician global assessment. So that is an objective assessment with the correlation with the subjective assessment. So what the PUCI is, pediatric ulcerative colitis activity index, it's the scoring system based on the symptoms like abdominal pain, rectal bleeding, stool consistency, number of the stools, nighttime symptoms, and activity level. And based on these categories, you give the score on each, and you categorize the patient. If the score is less than 10, it means the disease is in remission. If a score is between 10 to 35, it means mild disease. Between 35 to 65, it's moderate. And above 65, it's acute severe colitis. And for the Crohn's disease, we use the symptoms as well as the physical examination, and that can include the weight, height, abdominal examination, and also the extraintestinal manifestation. And a score is given for the each category, and higher the score, worse the disease is. Whereas the physician global assessment is a physician's assessment. It is based on the history and physical examination, but before the lab data. And patients are classified as having quiescent, means their disease is in remission, mild, moderate, or severe disease. So this is a single center retrospective electronic chart review involving all the children with IBD followed in the pediatric GI clinic at OUHSC. Charts were reviewed with the collection of data on age, ethnicity, disease location, lab values, including the inflammatory markers. The physician's notes were reviewed to see the physician global assessment and disease activity index, that can be PUCI or the PCDAI. And data was collected at 6 different office visits because we wanted to see that data is validated. The study was approved by IRB. So there were 165 patients that were enrolled in the study. 55% of the patients were Crohn's disease, 45% were the ulcerative colitis. In the Crohn's disease group, about 46% of the cohort was females and 54 were male, whereas in ulcerative colitis, 60% were female and 40% were male. The mean age in the Crohn's disease group was 12.5, and in the ulcerative colitis was 14 years. Regarding the disease location in Crohn's disease, ileocolonic was the most common disease, followed by the colonic and ileal location. Whereas in ulcerative colitis, pain colitis was the most common when you have inflammation from rectum to the cecum, followed by the left-sided UC and extensive proctitis. The ethnicity in the Crohn's disease group, the Caucasian were the majority of the patients were Caucasian, followed by African American. In ulcerative colitis, the same Caucasian, followed by the Asian, African American, and the Hispanic population. So the results, what it shows on the correlation of the mean platelet volume with the CRP, ESR, platelet, and albumin in all IBD patients. So on y-axis, we are seeing the correlation coefficient where 0 is showing no correlation. If you go up, means positive correlation. If you go down, it means negative correlation. What we found that mean platelet volume is positively correlated with albumin and negatively correlated with CRP, ESR, and platelet count. What does it mean? If you have a high CRP, if you have a high ESR and high platelet count, your MPV will be low. And if you have a high albumin, your MPV will be high. So this was the objective assessment, and with the subjective assessment, with the mean platelet volume, with the activity index, and the physician global assessment, both showed the negative correlation with the activity index and the physician global assessment. Just coming back, with the objective data, all the correlation was statistically significant, and with the subjective data, it was not statistically significant. We also did another calculation. So correlation of the mean platelet volume with all covariants was also calculated in the Crohn's disease group and the ulcerative colitis group. In Crohn's disease group, we found a positive correlation with albumin and a negative correlation with CRP, ESR, and platelet, which means same, like if you have a high CRP, ESR, and platelet, your mean platelet volume will be low. And with the subjective data of the activity index and the physician global assessment, it showed the negative correlation. And in ulcerative colitis, we found the same results, and it was statistically significant, and negative correlation of the mean platelet volume with the activity index and physician global assessment. So what was our conclusion? It was a mean platelet volume has a negative correlation with the CRP, ESR, platelets, activity index, and the physician global assessment, and has a positive correlation with albumin. The inverse correlation was statistically significant with CRP, ESR, platelet, and the albumin. Correlation of the MPV with the activity index and the physician global assessment was not statistically significant. The magnitude of the correlation was weaker in ulcerative colitis group as compared to the Crohn's disease group. This is the first pediatric study in pediatric IBD comparing the platelet index, mean platelet volume with other inflammatory markers, disease activity index, and physician global assessment. We also know that mean platelet volume is an inexpensive and already included in the CBC, so you don't have to order another test. It is an overlooked inflammatory marker in pediatric IBD. So the limitations of the study, it is a retrospective study and has no control group. Our study has not compared the mean platelet volume with the endoscopic and histologic assessment, which is a gold standard. What will be the future directions, keeping in view what we are trying to prove? So our finding, first of all, needs to be validated with more prospective studies. If this point is validated, then can MPV substitute the CRP and ESR, especially in the developing countries where cost and timings are the limitations? Can we only just follow the disease activity with mean platelet volume? If it is validated, can mean platelet volume be used as a marker for endoscopic remission? Can mean platelet volume be used as a marker for the treatment response? And if we are talking so much about the platelets in IBD, is there any role of the anti-platelet therapy in the IBD? I just want to acknowledge Dr. Marshall and Dr. Bruno, who are the principal investigator for this research, and Dr. Anderson, who did a statistical analysis on this research, and our program director, Dr. Altaf. Thank you.
Testing. Hi, good afternoon, everyone. Thank you for having me. Today, I will be discussing my study on osteopathic findings and treatment in children with abdominal pain, and this was a pilot study. I have no disclosures. My objectives for this study is to help you recognize pediatric functional abdominal pain, to define osteopathic manipulative treatment, or OMT, and to identify the appropriate use of OMT in pediatric abdominal pain. Today's focus will be on non-organic abdominal pain. This goes by a few names, including functional abdominal pain disorders and pain-predominant functional gastrointestinal disorders, or FGIDs. And this is the most common cause of chronic abdominal pain in children and adolescents. This is pain that cannot be explained on the basis of inflammatory, anatomic, metabolic, or neoplastic processes. This represents genuine pain. It's not psychogenic, it's not imaginary, it's not, quote, all in their head. This is pain that's as real to the patient as organic pain. And this was initially only a diagnosis of exclusion until the Rome criteria were established. The Rome criteria is a diagnostic manual similar to the DSM-4 in psychology that's used to classify and categorize functional disorders in gastroenterology. We are currently on our fourth iteration of this, known as the Rome 4. And I'd like to draw your attention to this disorder, functional abdominal pain not otherwise specified. The definition of this is that the pain must occur for at least 2 months in duration and needs to occur at least 4 times per month and include all of the following: episodic or continuous abdominal pain that does not occur solely during physiologic events, such as eating or menses, insufficient criteria for irritable bowel syndrome, functional dyspepsia, and abdominal migraine, meaning that there is no relationship to bowel movements, and after appropriate evaluation, the abdominal pain cannot be fully explained by another medical condition. When it comes to pain-predominant functional GI disorders, we usually start with a sensitizing medical event, such as inflammation from infection or allergies, distension from bloating, trauma, stress, or an underlying motility disorder. When this medical event combines with any genetic predispositions, such as a family history of similar disorders, changes in the gut microbiome, or early life events, we see the development of visceral hyperalgesia. And this is where the nerves in the viscera are much more sensitive than they would be in most people. And any movement in the viscera can be perceived as more painful than in others. When we combine sensitizing medical events with sensitizing psychosocial events, such as depression and anxiety, family stress, coping style, or secondary gains, with that visceral hyperalgesia, we can see disability develop. And this disability in our population often manifests as missing days of school or hospitalizations for pain. Now, we don't have a lot of great medications to treat this. As I stated, this is non-organic pain, so we don't have an organ to target. And so because of this, many pediatric gastroenterologists have looked to non-medical treatments. In a survey done in 2010 of American pediatric gastroenterologists, the most common non-medical treatment was lifestyle changes. And this makes sense. Exercise does tend to help people feel better. But the second most common was complementary medicine. Now, this is a very large basket of category. It includes acupuncture, hypnotherapy, but also included in this group is osteopathy. So what is osteopathy? Well, it was started by Dr. Andrew Taylor Still in the 1800s. And he founded the American School of Osteopathy, now A.T. Still University in Kirksville, Missouri, in 1892. He created the term DO for Doctor of Osteopathy. And over time, that has changed and now stands for Doctor of Osteopathic Medicine in the United States. So what is a DO? Well, like MDs, DOs in the United States are full physicians who complete 4 years of college, followed by 4 years of medical school. And during that training, they receive an additional 600 hours of training in the musculoskeletal system. And they're trained in OMT, osteopathic manipulative treatment. There are more than 96,000 DOs in the USA. Just as a show of hands, how many of you are DOs in the audience? All right, the few, the proud. So somatic dysfunction is the impaired or altered function of related components of the somatic system, including the skeletal, joint, and myofascial structures, and their related vascular, lymphatic, and neural elements. The signs of symptoms of somatic dysfunction go by the acronym TART, for tissue texture changes, asymmetry, restriction, and tenderness. And so we're looking for these changes in the musculoskeletal system during our physical exam. And once we find somatic dysfunction, we treat this with osteopathic manipulative treatment. And the goal of treatment is to correct asymmetry, restore full range of motion, and reduce tenderness. And I will do a demonstration right now on my colleague, Dr. Boston, who has been kind enough to volunteer for this. So, Dr. Boston, I'm going to have you stand here. So if Dr. Boston was my patient and he came into my clinic, I would do my typical physical exam with my stethoscope and all the good stuff. But for my osteopathic exam, I would start by palpating, come a little closer, palpating along his neck and palpating along his spine. And what I'm looking for is any areas that on the spinous processes that are rotated towards me. So if I notice any rotation, that's of concern. If I notice areas of tenderness, if I notice thickened paraspinal musculature, these are all things that I would then want to treat. So it feels like I got something right here, Dr. Boston. So it feels like right here you're rotated at about T4. Okay, so what I'm going to have you do, sir, is I'm going to have you grab your neck right here, and I'm going to have you grab your elbow with your other hand. Excellent. Okay? And what I'm going to do is a technique that goes by the name muscle energy. Don't let the name fool you. It's not mystical by any means. What I'm going to be doing is letting the patient use their own resistance to help correct this rotation in the spine. So normally the patient would be seated, so we're just going to simulate that for you. So under and over, and I'm going to rotate until I no longer feel, until I feel like he's now in line. I no longer feel resistance. Everything is stacked up. Dr. Boston, I'm going to have you try to go back to midline. Using 10% of your strength, I'm now pushing that spinous process back in. And relax. I now push him more rotation. All right, Dr. Boston, go ahead and go back to midline. Excellent. Relax. And turn again, and we're going to come right back up. And I'm going to have you relax. You can bring your arms to your side. And voila. We have now equal rotation on both sides. We're no longer more rotated on one side than another. And it's as simple as that. Thank you so much. So going back to the pathophysiology of functional GI disorders, you can imagine a patient who develops a viral gastroenteritis. They have mucosal inflammation. They've got gut microbes going on, having a good time in the gut. And this sends afferent signals to the brain that tells you, I feel pain. Your brain then sends signals back to your gut via the efferent signaling involving the sympathetic nervous system and the hypothalamic pituitary adrenal axis, which releases cortisol and norepinephrine. This can lead to further release of immune cells and mediators. And you can see that we have a cycle continuing where efferent signals are being sent to the gut, afferent signals are going back, and this pain persists. And you might recover from your viral gastroenteritis, yet this cycle of pain, this pain loop, persists. In osteopathy, you take it another step, and you look at what is connecting the brain and the gut. Well, we have a spinal cord that's connecting those. And that's where those efferent signals are traveling in something called the viscerosomatic reflex. So it's how things happening in the viscera manifest in the musculoskeletal system. And this can cause postural changes because you're sending efferent signals to the paraspinal musculature. And you can find palpable tissue texture changes, most commonly in the thoracic vertebrae, corresponding with the sympathetic nerve ganglia. You can also find palpable Chapman's reflexes. Now, these are tender points. They feel rubbery, kind of like the eraser end of a pencil, classically, and they are found to correspond with different visceral symptoms. In GI, these points can be found along the sternum in patients with pyloric dysfunction or in intercostal spaces corresponding with other organs. In patients who have a dysfunction of the large intestine, these points have classically been found along the iliotibial band, corresponding with different portions of the colon. So the target of OMT is to break this cycle of pain and break the feedback loop. And the target is really your efferent system. So looking at osteopathy and gastroenterology, OMT has been shown to help adults with abdominal pain secondary to IBS. Most recently, there were multiple studies done in Italy, which were randomized controlled trials looking at sham therapy, no relation to my name, and OMT. And they found that OMT was more helpful. And there are published studies correlating osteopathic findings with gastrointestinal endoscopic findings. This was most recently done in 2016 in Missouri, where they looked at patients who were scheduled for routine endoscopy, and in the pre-op area, they did this same osteopathic exam you saw me perform today, documented those changes, and then scoped the patients and saw that there was a correlation between the osteopathic findings and the endoscopic findings. But there are no published studies on osteopathic findings and pediatric abdominal pain. So with that, I took up the challenge and started the OMT study. So the primary objective of this study is to identify osteopathic findings in children with functional abdominal pain. And the secondary objective is to assess whether OMT decreases abdominal pain. My inclusion criteria were subjects ranging in age from 7 to 18 years with functional abdominal pain per Rome 4 criteria that I discussed earlier. All of my subjects were existing patients of the OU Pediatric GI Clinic who had already been diagnosed with functional abdominal pain. And some of these patients had been seen for years. The longest had been seeing us for 3 years. All subjects went through a 1-month washout period where there were no changes made to any existing medications, and no changes were made to their medications during the study itself. My exclusion criteria included rickets, RA, Downs, Marfan's, and Ehlers-Danlos syndrome. This is because these conditions include ligamentous laxity and brittle bones that could pose the patients at an increased risk for OMT. So at visit 1, consent and assent were obtained from the subject and the parent. All parents received the API questionnaire, Abdominal Pain Index Questionnaire, which is a validated questionnaire to monitor pain. And all subjects over age 10 also received this questionnaire. I completed a full osteopathic exam on these patients, looking at the every level of the spine, as you saw me demonstrate, as well as looking at the Chapman's points that I showed you earlier on the ribs and on the legs. And if I was to find any dysfunction, I treated those findings with OMT, as I demonstrated earlier. 2 weeks later, the subject came back. I gave every parent and every child over age 10 the API questionnaire, again completed a full osteopathic exam, and again treated any areas of dysfunction with OMT. This continued for 2 more visits, for a total of 4 visits. When the patients were at home in these 2-week intervals, they didn't do anything different. I did not want them to do anything different. So statistical analysis was completed with the help of Mike Anderson's team, and the data was analyzed using the Shapiro-Wilk test for normality and the paired t-test. So my results, I had 10 subjects successfully complete all 4 visits, 3 boys and 7 girls. They ranged in age from 7 to 17 years, and the median age was 12 and a half years. And 100% of subjects had positive osteopathic findings at the first visit. And these were found primarily in the thoracic spine, which you would expect given the sympathetic nerve ganglia. So looking at this graph, we're looking at the average abdominal pain index score from the questionnaires that were filled out by all parents and all children over age 10 at each visit. And we do see that across the board, we did have decrease in pain perceived by the child and perceived by the parent. Our parental pain level decreased significantly from visit 1 to 4. We did not achieve statistical significance in the child pain level decreasing, which might be because we did have a smaller sample size since not all of our subjects were able to reach to fill out this questionnaire. The mean spinal dysfunction is looking at the number of spine levels. So we're not looking at the severity of dysfunction, but solely at the number of spine levels that were involved, and we're looking at each visit. And we did have a decrease of the number of spine levels that contained dysfunction, and this decreased significantly throughout the study. The mean Chapman's points is looking at the number of Chapman's points that were found in those areas, and that also decreased throughout the study. Another way to look at the data is looking at the difference between each visit. And this graph is looking at the parent abdominal pain index and how the difference of that between study visits. And so from visit 1 to visit 4, we saw an improvement in pain. So the positive bars are your improvement in the pain level. And this was seen with statistical significance in the parent questionnaire with a p-value of 0.014. This is significant because it is the parents who brings the patient to the visits. So parental perception of pain is something very important to look at in any pediatric study. This graph looks at the mean of child abdominal pain index difference. Again, we see improvement from visit 1 to visit 4, however, not with statistical significance, which may be because we were not able to give the questionnaire to all of our subjects, only those over age 10. This is looking at the mean of spinal dysfunction difference. Again, we're looking at the number of spine levels that had dysfunction, and those the average number decreased with statistical significance from visit 1 to visit 3 with a p-value of 0.03, and from visit 1 to 4 with a p-value of 0.05. The important thing to note here is that this helps us in prognosis and in the long term. So when a patient comes to you and you want to do this, and they ask how many visits do I need to come to do this, you can tell them it can take as little as 3 visits to see improvement. And as far as the mean of Chapman's points difference, this was looking at the improvement in the number of Chapman's points at each visit. We did have improvement from visit 1 to visit 4. However, it was not with any statistical significance. And what this tells us is that Chapman's points may not have much relevance in this particular group because of it being non-organic pain or because of age, not quite clear, but we're not seeing it have as much significance. And so this can save the physician time by basically not needing to do this during their physical exam. The limitations of this study. It was a small pilot study. We had 10 subjects. There was no control group. This was not a blinded study. I was the only operator, so I knew what I was doing every time. And the abdominal pain index questionnaire could not be given to those subjects under age 10. And so the conclusion, osteopathic findings are present in children with abdominal pain. The treatment of those findings with OMT does correlate with improvement of parental perception of abdominal pain level. And this is the first study to examine osteopathic findings and OMT in children with functional abdominal pain in the United States. So I'd like you to take home these points. Functional abdominal pain disorders are the most common etiology of abdominal pain in pediatrics. The Rome 4 criteria is used to classify these disorders. And many providers and patients are looking for non-medical treatments for functional pain. And osteopathic manipulative treatment can be a useful adjunct therapy in these patients. These are my references. And I'd like to give a special thanks to my primary investigator, Dr. Halaby, my program director, Dr. Althoff, and my scholarly oversight committee, Dr. Grunow, Dr. Marshall, and Dr. Jacobs for all of their guidance. Thank you.
Thank you, Maryam and Rakesh. Excellent presentations. While we have Rakesh come over here as well. I think we'll open the forum for questions for both Maryam and Rakesh at the same time.
Yes.
Were you guys able to put together numbers for how our studies
You know what? That's an excellent question. We actually have not yet analyzed that portion, but it's definitely going to be needed for us for future research so that we can see how many subjects we need to obtain in the future. Yes?
What is forgive me for not knowing this, but the difference between chiropractic and osteopathy?
Yeah, that's a very common question we hear. So initially, when osteopathy started, Dr. Still was living at a time after the Civil War where many people called themselves doctor just because they did an apprenticeship under a doctor. They not necessarily going to school. So he created the schools of osteopathic medicine to create an actual school so that any of his graduates would walk around and say, I'm a DO, that means I went to a medical school. And initially, osteopaths only performed manipulation and did not prescribe medications. In the 1930s, with the advent of the Flexner Report and the change and modernization of medical education in the United States, requiring 4 years of college before medical school and requiring certain things to be a physician, the osteopathic community then came to a point where it needed to decide, are we going to be full-fledged physicians as the original intention was and include all of the things that MDs are doing, or do we only stick with manipulation? The group of physicians, the group of osteopaths who chose to only stay with manipulation went on to become chiropractors. And so that is the origin of chiropractic practices.
So the manipulation techniques are the same?
Yeah. So largely they are very similar. One of the big differences is that manipulation by chiropractors is heavily influenced on something called HVLA, or high velocity, low amplitude. So the cracking and popping that you typically might see done. And there is not much done as far as the fascia or the surrounding tissue. So oftentimes patients will have immediate relief, but the relief does not last very long if you only do HVLA. We are also trained in HVLA, but as physicians, we are also doing other forms of manipulation, such as the muscle energy that you saw. You would not see that in a chiropractic office. And so you don't have as a lasting an effect because you're only, with HVLA, only popping the bones and you're ignoring everything else that's there. And another important thing to note is that chiropractors are not physicians in the United States. And so oftentimes patients who might have more complex medical problems than just the musculoskeletal system might go undiagnosed or missed and might put themselves at undue harm if the whole picture of the patient is not taken into consideration. You're welcome. Yes. Yes.
I think the number went from like 25 to
Mm-hmm.
Is there some classifications of that abdominal pain index? Is it changed from about 20? So numbers.
Mm-hmm.
Is it clinically?
Yeah. So it was. Our statistician did tell us that this does show clinical significance, but it was not enough to cause statistical significance. The API itself does not separate between mild, moderate, severe as far as where it is. It really just gives you a number to trend that individual patient, which is one limitation of it, because often you'll see this with patients with functional pain. They tend to sometimes they can over-report their pain, and so they might start off with really high numbers and stay kind of in the higher end because even though they were functioning, so the perception of pain is a little altered from our typical pain scale of 1 to 10. But it did demonstrate clinical significance, although did not have statistical.
Is that developed for children, or is it developed
Yes.
validated?
No, it was developed for children by Vanderbilt. Mm-hmm. Yes.
This is a question about the platelet. So
I didn't find in the literature about any red blood cell indices in it, but there are multiple studies on multiple platelet indices, even the platelet grit and the platelet distribution width.
for example, in the red cell world, for example, if you have a microcytic anemia, you can use the red cell distribution width to differentiate between thalassemia minor versus iron deficiency. So it seems to be in the red cell world, it seems to be useful. And I'm just wondering if there is any derivative that you could extract from this data and maybe look at the distribution of the platelet volume in your patients.
Yeah, we can look at, but for platelet grit and platelet distribution width, you have to look each slide for those. We just did electronic because it's included in the CBC, so we just wanted something simple, not to look more into it. Six visits. Yeah.
So over time, did you find that were the patients all treated the same way?
No, but the treatment is optimized in each patient. Anytime we think that their disease is not well controlled, we step up therapy. So we try to put all these patients in remission. That's our goal. Yep.
Back to the abdominal pain. You talked about manipulation and all that in the back, I suppose that's clear. But what is thought to be the reason for the backs to go out of place or cause the dysfunction? What would be
Yes, so the theory is that when there is visceral pain, your viscera is sending pain signals or sending afferent signals to your brain, which interprets pain, but then your brain is sending efferent signals down back to your viscera that releases norepinephrine through the sympathetic nervous system, as well as cortisol through the HPA axis, and that at the same time those efferent signals are also running through the spine, and so your spine is an organizer of disease process, and that so efferent signals are also being sent to the paraspinal musculature, which is causing postural changes and thickening or rather palpable tissue texture changes at the paraspinal musculature as well, so that it's not just your stomach cramping, but also the areas of the ganglia and the spine nerves of that ganglia also innervates. That paraspinal musculature is also contracting, and that's leading to the back pain and back spasms that's associated with it.
Question I have, Maryam. So there were some studies for adults that have shown improvement in the IBS symptoms. So these adults were needing this OMT manipulation for a long time, or they had like a 1, 2, 3 month of OMT manipulation and they were good for rest for a long time?
Yes. So the subjects who were done in those studies did have also a shorter term, similar to the study of doing it over 2 months. They also had a set month, and they including in one of them they saw the patients for 2 months, 2 or 3 months, then 6 months later went back and looked at those patients again, and the majority of them no longer had any IBS symptoms. So, so it does show that there can be lasting relief. And looking at our subjects, we did have a fair number of our subjects were actually discharged from the clinic. One very notable patient, he had been seeing us for 3 years. He came and saw me and was bent over, stooped, walking like an old man. And by the end of the study, he was actually off of, after he came in for follow-up, he was off of all medications, and he was actually able to ride a horse and be in the rodeo as well. So it was pretty remarkable. We had a lot of fun doing the study and a lot of fun taking care of these kids that had really abandoned a lot of hope.
We'll take one more question and then probably we'll wrap up.
Yes.
I also have a question for Dr. Shambayati. You mentioned in addition to having fairly small hand, another limitation you mentioned was the lack of control group. And I'm sitting here trying to think, what would be an appropriate control group for this kind of study? And I'm curious as to what you have been thinking, presumably as you plan ahead to continue this to a more meaningful evaluation.
Yeah.
What would be your control group? How do you choose a control group for this kind of study?
Yeah, exactly. That is always difficult when it comes to many forms of complementary and alternative medicine, is finding a control group. Classically in OMT, sham therapy has been used, which is basically where you're putting your hands on the patient as if you were, for example, if my colleague Dr. Kumar was to pretend to do OMT on somebody as someone who's not trained, but could sort of mimic the movements, and you could see, is putting your hands on the patient really what's making the difference? You're really trying to determine, is there a placebo effect that's really showing you difference, or if there's actual change. Another approach with the study, and one of the reasons that, one of the ways I was looking at how would I use this in my own practice, being an osteopathic pediatric gastroenterologist, that this is a tool in my armamentarium that, that can be used alongside standard medical therapy. So one study that you could do would be having patients on standard, one arm of subjects being on a standard treatment, such as an anticholinergic, and having subjects be on anticholinergic plus OMT and comparing that. That would also be a possibility. But the classic randomized controlled trials done in OMT are traditionally done with sham therapy versus true OMT.
Also, the patients coming in the well child visit in the general pediatrics will be the best patients who are growing well, thriving, of the similar age. I think so that will be the good group also, because they don't have any signs or symptoms to come.
Yeah.
So that will be a good group too.
Yeah, exactly. So if you're looking for purely diagnostic value to see, are there also osteopathic findings found in children who do not have pain? I agree with Dr. Kumar. That is also a project that can be done. In Tulsa, where there is a pediatric osteopathic residency, they frequently do have studies done in their equivalent of Sooner Peds Clinic, where they do look at some osteopathic findings, particularly their most famous one being in otitis media versus regular kids without ear infections.
All right, if you have any questions, please come down. Thank you very much for presenting the